Thank you and good evening, everyone. Thank you for joining us for Sadhguru Center Speaker Series. My name is Tulsi Chase, and I'm the head of education and outreach at Sadhguru Center for a Conscious Planet. And we are happy to welcome you all to our speaker series, which are monthly virtual lectures and discussions highlighting the research and explorations of our multidisciplinary community of scientists, global experts, and thought leaders. So a little bit about Sadhguru Center for those who may be joining us for the first time. We are a multidisciplinary research center based at the Department of Anesthesia, Critical Care and Pain Medicine here at Beth Israel Deaconess Medical Center. And we aim to bring tools of well-being to both patients and healthcare providers to enhance consciousness, cognition, and compassion. Our work is at the nexus of research, education, and outreach. We offer wellness programs, conduct scientific studies in various communities, and bring together world leaders from diverse fields to collaborate and innovate health and well-being solutions. Today, we will be discussing the pertinent topic of sleep, or more so a lack of sleep, specifically looking at yogic breathing and mindfulness-based interventions for insomnia through the lens of research led by Dr. Michael Goldstein, who is a postdoctoral fellow in the Sleep and Inflammatory Systems Lab here at BIDMC. His research examines physiological mechanisms of mind-body interventions for insomnia, and he's also a licensed psychologist specializing in behavioral sleep medicine, having served as an interventionist on several recent clinical trial studies for insomnia. So thank you so much, Dr. Goldstein, for joining us today, and please go ahead and share your screens and take it away.
Yeah, so excited to share a bit about yogic breathing, mindfulness, other practices, and sleep, really focusing also on insomnia and how we understand these practices in their effects on sleep, particularly when sleep is disrupted in the case of insomnia. So it's a really fascinating area, and we'll do an experiential practice together to be a bit, live on the same page about some of the practices that I'll be covering, and then cover conceptually some of the research with some specific studies as example data. So yes, to begin, we can do a mindful breathing practice together. And I intentionally show just a general schematic here without a facial expression, reminding us that the aim of many of these practices isn't to cultivate only one particular state of mind or emotion, but rather more a sharpening of attention, an ability of awareness, an ability for flexibility and dynamic experience that's not just necessarily one thing. And this is an important theme as we'll apply it to our understanding of insomnia and how mind-body practices, yogic breathing, mindfulness may be really helpful for insomnia. So and we'll just do this for 1 minute, very brief practice. Just letting yourself get settled and checking in with the state of your mind in this moment. And then we will use the breath as a tool to practice attention. So we won't do a particular tradition of breathing or yoga practice in this moment. More, I'm using it as a tool to highlight the components that are often involved in a variety of yogic breathing practices. So you can become aware of your natural breathing rhythm in this moment. Observe the inhale and exhale. And then we'll take a few breaths together, and I'll attempt to make my breath audible, and then I'll use a hand motion of inhale and exhale. So I'll try to use my hands in case that's more helpful. So at the end of your next exhale, breathe in and out. And inhale and exhale. continue a few more rounds of this pace of breathing. Now really noticing the experience of this practice, the qualities of sensation, emotions, noticing any thoughts as you continue another couple rounds. And then allow your breathing to return to a natural rhythm while continuing to observe your experience of breathing. The quality and state of your mind as you're observing your breathing. All right, and then we will come back together. And so this was a practice highlighting, at first, we did a paced breathing together, and then we added in an intention of mindful practice, and then pulled away the breathing and continued to practice mindfulness. So the idea here, as we get into some just terminology, again, to make sure that we're all on the same page. And in this talk, I'm going to use MBIs as mind-body interventions. So really this is a broad umbrella of many different practices, but it is also used as mindfulness-based interventions in the literature. And the idea is, so there's mindfulness practices, and just to note that that may be a designated on the cushion meditation practice or a more applied version of mindfulness in daily life. And then within a variety of yogic traditions, there are forms of yogic breathing, which here I'm defining as paced breathing of some sort or some rhythm of breathing with mindful attention. And so correspondingly, there are components of slow-paced breathing or another form of rhythm, just recognizing that there are many forms of yogic breathing practices with many different rhythms. So again, I'm defining it as including mindfulness. So each of these practices alone is not necessarily yogic breathing. And yogic breathing may be one component along with movement in many yoga practices, similar for Tai Chi, Qigong, and many more. And so really getting into the research lens of these practices now, we could use a variety of schemas. This is one that might be helpful, where we kind of contrast practices in terms of physiological mechanisms. We may have more top-down influence, so this could be from the brain, and correspondingly in terms of phenomenology or experience, the mind and cognitive aspects. In contrast, from more bottom-up, or in the case of breathing practices, from our belly, our abdomen, that are directly engaged in the breathing piece. That's one dimension. And then another may be a distinction between whether we're trying to control certain aspects of our experience, or more openly have an acceptance-based approach with observational awareness. And here are a few practices that may fit in this matrix. So cognitive techniques being very control-based and top-down. So this is traditional stress reappraisal. If you're in a stressful situation, reminding yourself that you've been in similar situations before, and therefore you can go through this one. And in contrast, mindfulness alone as a quality of state of mind that is being practiced may be more acceptance-based, but still top-down. Breathing by itself without mindfulness may be control-based, really controlling a rhythm. And then what's that when that's combined with mindfulness, that may be somewhere here. So just to really pull apart some of these pieces. Here's an example of one recent research paper by some colleagues at Arizona that was in Psychosomatic Medicine, and a really great paper and with the title including yogic breathing. So seems really exciting. It's digging into some of the physiology of yogic breathing. Why do these different terminologies matter? Well, in this case, there wasn't really a component of mindful awareness. It was really paced breathing. And so it may matter mechanistically, and then therefore how we can strengthen interventions. And so so there are a variety of these cases where these terms get a bit confused. And applying this research in the clinic, it could matter because there is some persisting stigma around mind-body practices and mindfulness, for example. And so we might imagine many individuals having a reluctance in the clinic to practice mindfulness, but maybe a lot of natural motivation to control their breathing and do a structured breathing practice. And then, as already mentioned, it can really help to understand mechanisms by separating these components. And one practice I'll talk a bit more about in a bit is Sudarshan Kriya Yoga, or Sky. And that practice is a great example that many mind-body practices actually have many components of them. In addition to breathing, mindfulness, there may be other forms of meditation or movement, as well as encouragements, at least, if not explicit instructions, around nutrition, maybe even playing games and laughter that may be related to the games, or even an explicit laughter yoga, and emphasis on social connection, service, and some mention sleep as well. For the most part, today I'm actually talking about sleep really just as the effects or outcomes of these practices, rather than explicitly applying the practices to nighttime sleep, though we can certainly talk more about that at the end. So to just be on the same page about EEG, electroencephalography, measures related to these practices. This is an example of some typical rhythms that we would observe. So this is the electrical activity recorded from the scalp in these different states of consciousness, from wakefulness to sleep. And we can see these shorter amplitude squiggly waves of what we call beta or gamma band rhythms. And here are some of the typical slow waves of deep slow wave sleep. And even during that form of sleep, there may still be some of this higher frequency beta gamma activity. And on the right, we can see an example of spectral analysis, which is a way to quantify all of the different components of this signal in one figure. So on the x-axis is the frequency. So the higher frequency beta gamma is to the right. The lower frequency or slower waves of these delta rhythms is this to the left. And then there's some other pieces such as the sleep spindles here that are this little bump here. And in general, we see that insomnia tends to have more of this high frequency beta gamma power during non-REM sleep that's even on top of these slower oscillations. And this was a focus of a lot of early research in insomnia, elevated beta gamma power, as well as some observations of alpha delta sleep. And these were interpreted as markers of hyperarousal, so the brain being too active while it's asleep, and that is interfering with natural restorative sleep. And at the same time, starting in the 60s and 70s and forward, some meditation studies during wakefulness as well as sleep were observing increased alpha power, which during wakefulness has been interpreted as a marker of relaxation used for biofeedback. And then more recent research has made things a little bit more interesting. And there continues to be observation of elevated beta gamma. There was a great recent meta-analysis that found overall patterns across many studies indicating this increase in beta gamma, possibly also in the lower frequency range, and reduced slow wave sleep or slow wave activity, suggesting less robust restorative sleep in insomnia. And in meditation, now more recently, and I'll show some of the data in a moment, there's also an observation of increased beta gamma power during non-REM sleep. So in a way, meditation seems to make people appear like they have insomnia. And this has been very confusing to the field so far. And this is thought, again, to reflect hyperarousal because during wakefulness, this beta gamma power is a marker of sharp focus and attention and engaging with the task. So then we can step back and say, wait, well, so what is then a EEG marker of good sleep if we're seeing this in both a condition of bad sleep and a condition that we might oversimplify as good sleep? I'll come back to in a moment with meditation. And bottom line, we need to consider the context, the experience, phenomenology, along with the EEG signals. Now, I just want to also make it very clear that when it comes to improving sleep, cognitive behavioral therapy for insomnia is the first line intervention for insomnia. And these other practices, including sleep hygiene, may be more for general improvements for sleep, but can be misused as interventions for more significant sleep disruption. And same if there's obstructive sleep apnea or other conditions that are disrupting sleep that may require other interventions. So I do want to just emphasize that mind-body interventions seem to be very helpful. However, the literature is still developing to really have them be a prominent treatment for sleep disruption, and we do have many other great tools at our resource. So, where do mind-body interventions fit into these? And I'll certainly recommend that if there is sleep disruption, that everybody consults their primary care physician or behavioral health provider. Remembering that CBTI is the first line intervention for insomnia. And then also remembering that from an integrative medicine lens, if you enjoy these practices or a patient enjoys these practices, then of course, if they seem to be safe, then they can be helpful. And so then how does this change clinical practice? It might not immediately change what we do in clinic. However, certainly in a research lens, it can help shift how we're thinking about these physiological measures, especially to qualify them and contextualize them with experience, and to integrate these into interventions. And acceptance and commitment therapy, ACT, is a burgeoning area in clinical psychology, and for many different clinical conditions that really integrates mindfulness into more traditional cognitive behavioral therapy and other modalities. And that has been the case for mindfulness-based therapy for insomnia as well. And long-term, this can really spare some headaches and improve outcomes because it increases and really focuses on flexibility rather than trying to change an outcome. So I just want to give that preface right off the bat, and then I'll go quickly through some other work, and then we can come back to it if there are specific questions. And that will cover some more EEG data, as well as some autonomic nervous system activity, such as heart rate variability. And this is a general schema in terms of how these domains relate that I use as a framework, so to just keep that in mind. And I'm going through kind of an iterative process of kind of reinforcing this notion that we've conventionally thought of insomnia from a hyperarousal model, that it is too much wakefulness or alertness during sleep, and it interferes with a natural sleep process. And that may benefit from a bit of innovation that is obvious yet somehow innovative, that insomnia can be really an interaction of arousal and how we appraise it. And there have been many notions of this in the past, to just add some flexibility, make it a more relational understanding rather than what could be isomorphic, one-to-one, where it's, this EEG rhythm equals this experience of sleep, or dichotomous, that this is good and this is bad. And so just recognizing these are obvious ideas, yet I think we still have a ways to go to better understand and map them out. So now coming to the experience of insomnia. This is a common example, and many of us, even if we might not consider ourselves struggling with insomnia, can relate probably to one or two nights of this experience. And to really make clear that insomnia is a persisting difficulty falling asleep or complaint of non-restorative sleep, generally 3 nights a week at least, and often for 3 months or more. There are a few different ways of categorizing it clinically. Previously, there have been other types of, some subtypes. However, surprisingly, we have not had reproducible, consistent evidence in the research literature. I think because we are kind of not often capturing the full scope of evidence. It's often either the subjective complaints or the objective physiological data. And so this has been really consistent across a number of studies, taking this hyperarousal lens on insomnia. And so to just show a few of those, and this model, which is really integrating a lot of these domains of evidence. And in red are the domains that are more pieces of evidence of physiological arousal. And there's evidence supporting each of these. So it's not that it's false, it's just maybe not the full story. And just this again for reference of variations in EEG rhythms. And here are some of the many individual studies, including some that use these EEG markers during childhood to predict onset of insomnia symptoms during adolescence. So this has had a consistent line of research over time, supporting this idea of hyperarousal in EEG for insomnia. Now, to show 3 separate studies that show very similar evidence, higher beta, gamma, high frequency EEG activity during non-REM sleep, but associated with meditation and either improved sleep or at least no complaint of sleep. So this is in long-term meditators and proportionate to thousands of hours of lifetime practice, with a broad but maybe particular distribution on the scalp. So this is like a bird's eye view on top of the head. So this posterior central area seems to maybe be most prominent with this pattern. And this is similar to what we find in insomnia versus good sleepers. And then these are a few different ways of visualizing the data. But again, we can see a broader separation of the lines. Red is the control of no intervention, and the blue is in 8 weeks of a mindfulness-based intervention, increasing this higher frequency range activity. And then this is another case with insomnia, and an increase from baseline to 6 months, so a longer term effect in this higher frequency range that shifted a relationship between this activity and insomnia symptoms that didn't have a clear relationship at baseline to maybe a more evident relationship with more of this high frequency beta power and lower insomnia symptom severity or insomnia severity index score. So this is kind of shaking up that notion that this activity is just bad and correlated with poor sleep. Interestingly, this has been found in earlier research studies, and of course, the thousands of years of literature and practice of these techniques. And Willoughby Britton and colleagues have done a great job really highlighting this and highlighting that it's a balance of practices around calmness, relaxation, and alertness. And again, this has been kind of carried forward into more standalone therapies or full therapies for insomnia. Again, this is that experience, and we can see this recognition of I can't sleep, and that's a primary complaint, a primary mode of arousal. And then where we get kind of stuck is our secondary, our follow-up to that recognition that we can't sleep. And this is where the mind really can take off. And this was captured by Jason Ong and colleagues as a metacognitive model of insomnia, that it's really this secondary arousal that keeps us stuck in the cycle, which again is presumed to be associated with physiological arousal, but this model doesn't fully capture that. So this is a metaphor that might offer just some added complexity to this picture. So we can kind of imagine that there's a fire in the house, and that's a bad thing. We want to put out the fire so that there's no fire in the house. And this tends to be the approach of cognitive behavioral therapy for insomnia and relaxation practices to de-arouse, reduce this physiological arousal, which is often, again, presumed to correlate with cognitive arousal. And the catch is that there can be low levels of arousal and still insomnia and disrupted sleep. So these aren't inherently related. So we might fix it and have a smile, or we may still be frowning because of poor sleep. So mindfulness practices and other mind-body practices may give a platform to, in this metaphor, put the fire in a fireplace and give it a constructive context, and in that way it can actually be an adaptive feature, this arousal or alertness, and with practice or time there may be some modulation of increasing and decreasing that arousal through these practices, so this increased flexibility. But importantly, there's this area of the matrix that previously wasn't well accounted for, where it's either arousal or flexibility, and this shows that maybe they could go together. And I wanted to just recognize this small little arrow here is that some mind-body practices and mindfulness can induce insomnia. And so to not add too much complexity to the picture, but that is an observed occurrence. So we're just continuing to increase the research base on these practices. So this is just meditation and sleep on PubMed, And more recently, it just continues in an exponential trend, fortunately. Even just on Google, this is from Google Trends, so people just searching meditation and another term, meditation and sleep has really continued to take off. And surprisingly, with very little change, relatively speaking, with depression or happiness or performance, and maybe they're not the exact search terms, but it really shows this interest in meditation for sleep over time. And it's being progressively covered by some popular media outlets. So this was one that some colleagues and I contributed to, although I guess it can still be hard to compete with some of these other topics at the top, but it is gaining recognition. And so then to bring in the autonomic system, so classically thought of as parasympathetic, the rest and digest system, versus sympathetic, fight, flight, freeze, activation system, and its regulation. And so this was a simple model that colleagues and I presented a couple of years ago of really recognizing the central role, and here, importantly, separating the subjective sleep complaints with the objective physiological sleep disturbances, and that both, and maybe especially together, relate with these longer-term health and disease outcomes. This might be a way to further separate them, where insomnia and mindfulness practices may have a shared effect of increasing this cortical activation, but maybe have divergent effects on autonomic regulation. Simplified as improved heart rate variability during sleep and also wakefulness with mind-body practices such as mindfulness, and decreased or dysregulated in insomnia. And just recognizing this is part of, again, a complex picture with many different domains and measures. And it could be really interesting. And so here I just want to highlight and really just encourage future research to look into these approaches to studying mind-body interventions in insomnia. So cortical autonomic coupling, really directly linking these domains. And that could be shown with a time course of these measures. So this is all-night data. And on the top is a hypnogram, so the stages of sleep from wakefulness to deep non-REM to REM sleep across the night, and corresponding EEG slow wave activity, heart rate variability, and also that beta gamma power. And we can see that there's some correspondence between the cortical activation and heart rate variability as an autonomic measure. And there are great examples of a few different ways of calculating these measures. This was one of those great time course, detailed time course correspondence between the EEG slow wave activity and high frequency heart rate variability. It's a little bit mixed though, and part of that is because some of these measures have clear relationships, and some have very fuzzy relationships with variability across studies as well. So these are just a few examples of that, but especially in insomnia, this cortical autonomic coupling has not had a consistent research literature so far. And then if there are folks interested in learning more about these practices and how to analyze data and not only produce the very colorful visuals, but to really dig into time course and full spectral patterns and topography, etc. This is a great resource that you can search for that. And here's some more of those visuals where we can really appreciate the richness of the data. And this is beat-to-beat blood pressure changing across the night as a function of sleep stage and sleep depth. And so, again, it's really just showing and appreciating the richness of these data. There is a trade-off between how easily we can measure these domains. Blood pressure, heart rate, especially with these wearable devices, is wonderfully easier and easier to measure. However, we continue to need these more invasive and very rigorous procedures to gain better specificity and accuracy in many cases. So to just keep this in mind, that there's a trade-off. But we can be a bit more systematic in looking at this whole picture together. And one way can be this overlapping Venn diagram type approach, where we really fit all of these different domains of measures into corresponding areas. So there may be some shared measures between kind of insomnia as a clinical disorder, as well as sleep disruption from resident or shift work schedules and other occupations associated with sleep loss. As these practices that entrain both calmness and alertness. So just briefly, a little bit of data. This was a study that I completed a few years ago, comparing this yogic breathing practice that I had mentioned earlier, Sudarshan Kriya Yoga, with a more cognitive-based approach. Again, stress reappraisal and more conventional CBT practices. And just a couple examples that really distinguished these two active interventions, and they were controlled for time and even location and number of participants in these group workshops, etc., and had comparable ratings in terms of experience in the workshop, but some differences in outcomes. So they both, and so in purple is the Sudarshan Kriya Yoga, green is this cognitive wisdom on wellness workshop, and then gray is the between group effect size. So there was a clear improvement acutely. So the solid bars are the pre to post effects, and then these patterned bars are the long-term 3-month follow-up. So both groups had a short-term increase of about medium to large effect size in social connectedness questionnaire ratings, but the yogic breathing seemed to have more persisting effects, similar for perceived stress, as well as sleep disturbance. And then we also had them come in for a laboratory stress induction, measuring their heart rate. So here's their heart rate at baseline, and then when they were reading the instructions for this experimental stress task, put their hands in ice cold water, and then switched between that and doing a math task, subtracting a large number in sequence and getting negative feedback. So it was an intensely stressful task. And here's the elevated heart rate with that as a whole group that later did fully recover towards their baseline heart rate. But most interesting is when the two groups came back after the intervention. So you can imagine going back to the same lab room where you did this stress task, and when you go back, you know what's coming, and so you're anticipating the stress. And you may have a faster breathing rate, just sitting there quietly, but knowing what's coming. And so this is what we observed in the cognitive group, this anticipatory stress in both breathing rate and heart rate. But the yogic breathing practice seemed to buffer that effect and have kind of a mitigated change in their breathing rate as well as heart rate. Another example of this was, again, with the Sudarshan Kriya yoga practice and just recovery in heart rate from a bicycle challenge. So the participants were on a stationary bicycle, and they biked, they rested for 5 minutes, biked a mile for as hard as they could, and then recovered another 5 minutes. And this is inverse of heart rate. It's the interbeat interval. So lower is a faster heart rate. And so here's how quickly that heart rate recovered. And when we compared these two pre and post, the traditional ways of just doing heart rate variability or comparing effort versus recovery seemed to not really show much of a difference, but visually we can see this curve is a lot steeper than this one. And so when we really did a more detailed approach, we saw that indeed there was a faster heart rate recovery after the yogic breathing training, even though there wasn't an explicit exercise-based component to it. But it leaves a lot of open questions about what that is. So more recently, we've finished a pilot study that is continuing this approach of separating these different pieces of mind-body practices with the ultimate vision of applying that back to sleep and seeing if we can better understand the effects of these practices on sleep. So for this, we just brought in a small sample of 18 participants, generally healthy, no sleep disruption, also no significant sleep disruption that could tell, and no prior or minimal prior mind-body practice, and randomize them to either slow-paced breathing, mindfulness, or the combination, yogic breathing, today. And this was all done remotely, and there were 2 weeks of sleep logs, and then a 24-hour recording of ongoing heart rate, beat-to-beat heart rate measurement with a puller chest strap for heart rate. And during the visit, they received initial training on one of these three practices, guided audio that they to practice for 8 weeks, and then repeated that design afterwards, after the 8 weeks. And again, it's this, and and basically we saw great adherence, and we can talk more about that with the daily sleep logs. So we had great response in doing these measures, as well as for the daily practice, and to really measure that in detail with, again, this Polar's chest strap, and then some apps that were imported to MATLAB, where we got a really detailed visualization of their data, with some of these rhythms being clearly evident in the spectral profile, similar to what I showed for the EEG data earlier. So this contrasts the baseline and doing a slow-paced breathing, so we could really clearly see that they were doing those assigned practices. So great news, it seemed to be doable, at least on this small scale. And we saw that indeed the groups differed in their breathing rate compared to the mindfulness group. So those instructed to breathe more slowly, indeed breathe more slowly or consistently so. And the mindfulness groups appeared to increase more as a group in terms of mindfulness scores. And this was in the context of general improvements in life satisfaction and some other measures. And then we can really see differences between the groups in their spectral profiles of heart rate variability during the daily practices. And so, but then did these interventions really improve sleep? Very briefly, I'll just say that there were some indications of differential improvement, maybe with sleep efficiency, but not overwhelmingly so. And so we're continuing to analyze the very detailed daily sleep logs, as well as overnight heart rate variability, where we can really see these rhythms. In short, without explaining all the details of this, we can see this pattern of their breathing rate. So this corresponds to the peak in the spectral profile, same image that I've shown for those other visuals. But we can see these in detail. And then just from pattern recognition, right, we can see these lines with some variation across all these different recordings, and these are different participants. So there's a lot that we can do there. And so moving forward is that we can just basically continue digging in, systematically comparing these different domains of measurement, and looking at time course, and and to continue, I guess, breaking down all these pieces of the different interventions and outcomes. And this can really, it parallels a lot of work that's been done in fields of stress research, general interventions in health outcomes research, and even kind of applying this social lens and in connectedness. So just want to thank many folks who have influenced these conversations, and I hope I've left enough time for some questions and discussion.
Michael, thank you so much for that conversation, actually the talk, right? And breaking down individual components and giving context to the entire research. Seems like the contextuality is the most important part that I took away from this whole talk, rather than just going with EEG, but you want to really contextualize and talk about it. Especially, meditation and sleep having similar EEG patterns. It seems like one has to do that. I'm not sure if anyone else has any questions, so until they raise their hands, I'll keep asking you. So one of the problems that we have is the control groups they ask us for. How do you actually deal with it? And you even said in one place that there is no randomization. In the SKY study that you published, where they randomized, and how did you do that?
Yes, fully randomized. So it was advertised as a stress management intervention study and was not explained or emphasized in the requirement that one intervention is mind-body, mindfulness, breathing related, and one is more cognitive. So everybody gets the same message, and I think importantly, not advertised as a mind-body practice study. And then, quasi-randomized, so that participants who know each other are randomized into the same group. And I guess it seems strategic to have these active comparison interventions. I mean, ideally is like the yogic breathing intervention, the passive control wait list, and then some type of active control. And so I think there's arguments for either approach, to have a passive control or an active control. And sometimes the active control is too high of a bar to compare with. But I think if there's a strategic contrast, that's where there seems to be the kind of biggest impact. So if it's a breathing focused practice, then to extract out the breathing and have it be only the mental component of it, or to compare with other existing practices, whether it's like a CBT related stress, or kind of if it's for depression or anxiety, those types of interventions, or even just exercise, something else that can compare actively with it.
So you, in effect, you have three groups, right? One intervention, one active control, and one passive control. Is that right?
Yeah, I think that that's ideal. And then you have the passive control, assuming just natural improvements in many cases. And so I think that that's often undervalued or under-recognized, is in many of these wellness studies, people want to get better. And so just over time, they're likely to improve. And so to have some measurement of that.
So I might not have listened to you on that particular couple of slides. And so in that particular study that you published in 2020, the primary outcome, or the, when you say sleep got better with the yogic intervention, what was the primary outcome?
For that one, just the Pittsburgh Sleep Quality Index.
Mm-hmm.
So that was here. So the Pittsburgh Sleep Quality Index is a measure of sleep disturbance. So sleep disturbance reduced and was similar between groups acutely, but then the cognitive group seemed to return to their baseline levels of sleep disturbance, and the yogic breathing maintained its improvements, its reduction in sleep disturbance. According
this is
to
over how many weeks is that?
3 months.
Okay.
So
Right.
the workshop was actually only 4 days. It was kind of stress management boot camp with this yogic breathing practice, and then measured 3 months later.
All right. Akshay has his hands up. Akshay, do you want to?
Yeah. Hi, Dr. Goldstein. Thank you so much for the very thoughtful and informative presentation. I was just wondering that I've been reading a little bit about there seems to be a small subset of people who are naturally shorter sleepers without the cognitive impairments that the rest of us experience when we sleep as little as them. So it's generally 4 to 6 hours is all they need compared to 6 to 8 hours for the rest of us. And some people have been trying to find out what genetically is different about them, but if you were to hazard a guess, what has to be different physiologically in those people for them to be, what functions, what difference should there be biologically for them to do the cognitive recovery functions at the same level as someone who sleeps, who needs much more sleep?
Right, yes. There do seem to be strong genetic factors in resilience to shorter sleep. So resilience to sleep loss, and then correspondingly just shorter sleep duration naturally on a consistent basis. And so I think that's a great question that still needs a lot more research to better understand. There, in some case, so one simple explanation from sleep research is that the shorter sleep folks have more robust homeostatic sleep drive. So let's see. We look here, we see, this is a great example. So these lower bars here and corresponding peaks in this delta power of the EEG, you can see that kind of the biggest, most robust pattern of this is later in the night. So it could be that the shorter sleep folks have this earlier in the night. It's more consolidated. And so it's conferring those benefits of restorative sleep in a shorter duration. That's one possible explanation. and correspondingly, there may be better regulated autonomic function during sleep, and possibly better correspondence between those two domains. I think there are a number of other explanations that are possible, but just offer a few.
And
So,
similarly,
yeah.
so if you were to suppose give an intervention to people that was activating their parasympathetic nervous system, and you were seeing that their body is less, the resting heart rate is lower compared to their baseline. Is there a correlation between lower resting heart rate and duration of sleep, or how much slow wave power is seen on the EEG? I'm thinking about this in the context of if you were to give a mind-body intervention and people report that they now sleep less without cognitive impairments, what would be happening? Exactly.
Right. So one question, if I understand you, is does kind of heart rate early on here predict whether it's EEG or heart rate variability later on in the night? And then here was a great evidence of heart rate during the sleep onset period relating to heart rate during slow wave sleep the rest of the night. So essentially just measuring it at the sleep onset period could be enough to give an insight into what the rest of the night might be like. But I think besides that, it's kind of an open question of how these practices influence that.
Thank you.
See, one other thing you showed is the characteristics of EEG between meditators and insomnia patients. When you talked about meditators, and when you said that increased beta gamma pattern in meditators, right? Was it an aggregate of the entire sleep duration, or was it also based on the early versus late versus mid times of the sleep?
This study with long-term meditators, I recall, had fairly consistent findings from the whole night and early night non-REM, later night non-REM. It hasn't been looked at much in REM sleep, although the hyperarousal approach to insomnia tends to focus more on non-REM sleep, because that's when there should be the least amount of this higher frequency activation. And so at least in those studies and in my own, some of these others are just too small of a sample size. So there ends up being too much noise for those shorter time periods. And so the whole night non-REM is the most stable statistically. But it doesn't appear to have a consistent pattern of a certain time of the night. It seems to be more global across the whole night.
Great, thank you so much again. If anyone else has any questions.
Michael, very nice talk. Could you go back to the spectrograms of your pilot study? I didn't quite understand what you were pointing out some patterns.
Sure.
Can you just go into a little more detail of what you're finding?
Certainly, yeah. So here is an example of the heart rate changing over time. So this is just the time domain trace in the bottom of the paced breathing practice. And so we can see these consistent rhythms here in the middle. And these consistent rhythms are then captured with spectral analysis. So spectral analysis trying to capture what amplitude is specific to what frequency in the time signal. So we can basically see kind of here, there's a much more variable pattern. And so there's more variable pattern here in the spectral analysis. here is a prominent pattern corresponding to the breathing that then corresponds to this peak at, and then the dashed line is what we would expect based on 6 breaths per minute. So this peak corresponds to the rhythm, and we see something similar in the overnight data. The peak is closer to 15 breaths per minute, the more natural breathing rate. And so this red line across the night is breathing rate.
Okay, so it peaks at 15 hertz, basically.
Yeah, 15 breaths per minute, so about 0.25.
15 breaths per minute. Yeah, that hertz, of course. Yeah, and it correlates with the EEG in some way.
A bit. You can kind of see these patterns here. That is probably the REM sleep periods. So here's falling asleep, where and higher of the line would be faster breathing. And so breathing slows down, stable non-REM sleep, and then REM sleep, and then non-REM, and so on. And then speeds back up a little bit as the person wakes up. So presumably, here I only have the heart rate data, but it likely corresponds to the slow wave activity given these pieces of evidence. And we see that here as well.
Yeah, so that's the other question I had. And can you talk a little more about why you think there's a correlation between HRV and like slow and delta EEG?
Well, there's certainly kind of the simplest explanation, kind of going back to the classic definitions of parasympathetic versus sympathetic. So high frequency heart rate variability being generally more associated with parasympathetic activation, rest, and digest. That physiological state being then associated with more of the high frequency of the heart rate variability, and less with the high frequency EEG. So there's some confusion of, so high frequency heart rate variability is a positive measure of parasympathetic activation, which is increased as we are in deep non-REM sleep. And then the EEG is relatively less activated in the higher frequencies, beta and gamma, and more prominent in those slower frequencies. So simple explanation is it's a function of that generalized physiological state of parasympathetic rest and digest during non-REM sleep, but then that changes for REM sleep, much more active and mixed. Yeah.
Okay, thank you.
Michael, thanks again, and we'll continue discussion on the rest study offhand.
Wonderful.
Yeah, Tulsi, you can close it out.
Thank you so much, Dr. Goldstein, for joining us today and sharing such interesting research with us. I am sure that we'll have many things to connect with you about as we continue. But thank you to everyone who has joined us today for your insightful questions and your participation. Please continue to join us for our monthly speaker series events. And if you'd like to get any more updates on Sadhguru Center's programs and events, there's a link in the chat you should be able to open, and you can certainly let us know of your interest, and you can also reach us at the email provided. Thank you again, all of you, and have a lovely rest of your evening, and we look forward to seeing you next month.